Well, hello, everybody, and thank you for joining us today during Hunger and Homelessness Awareness Week. Today is going to be part 2 in our series looking at mental health and homelessness. And I'm really excited to continue this dialogue around really important subjects. This Awareness Week has been a group effort of over 20 different local organizations that have a shared vision for involving the community in bringing about changes to the lives of anyone who's affected by homelessness and housing insecurity. These organizations picked the theme of changing the conversation for our week of activities. And we have actually been busy doing things since the 1st of November. So I'm really excited for this conversation. We did have part 1 a week ago. Part 1 is up on our YouTube, and I'm sure a link is going to be popping into the chat box. So if you missed part 1, feel free to watch that another time. If you joined us for part 1 and you're back for part 2, welcome back. I neglected to explain who I was, so I'm going to do that right now. My name is Bex Hayco. I am the Executive Director of United to End Homelessness with Orange County United Way. We know that the intersections of mental health and homelessness are major areas where there is some potential for confusion, some potential for conflict, and that these are really nuanced conversations that it's important to take time to discuss. So as I mentioned, this is part 2. We will be having part 3 after Thanksgiving, and so I hope you'll be able to join us for that one as well. I do want to recognize that these topics can be difficult discussions, and mental health can affect all of us and certainly does affect all of us. And so being mindful of that, I do want to recognize the resource that was being displayed before we kicked this off. The phone number 988 is available. If anybody wants to reach out for help, you can dial 988 to be able to get some assistance. So moving us on into starting today, I am really thrilled to be joined by 2 colleagues, 2 women that I have a lot of respect for who bring such varied backgrounds and expertise to this discussion. So I'm thrilled to be joined by Kelly Bruno-Nelson from CalOptima and Christina Weckerly-Ramirez from the OC Healthcare Agency. So I would love for you to just introduce yourselves. Tell us a little bit about how you got into this field and what inspires you. And Christina, I'll come to you first.
Thanks. Okay, thanks. It takes me a minute to unmute and figure out my technology, even to this day. So I work for the healthcare agency. I oversee our outreach and engagement services, and we reside in within the healthcare agency under mental health and recovery services. And our service is to go out on the streets, connect with individuals who are experiencing unsheltered homelessness or the unhoused population, and connect with them and really connect them to services. And I guess what got me started in this is literally doing outreach to substance users who were out of treatment. Many of them were doing sex work or other kind of engaging in what we call at-risk behaviors in order to survive on the streets, and connecting with them, trying to get them to reintegrate into the community, be seen, be heard. And I just fell in love with this work. I fell in love with the fact that I feel like they're at hope versus at risk. I feel like the population needs to be seen and feel like they belong to the rest of us as a community. And it just really gave a great opportunity to feel that connection and to be of service. I found out that I am not great at doing it every day because I don't have a thick enough skin. So I admire people who can do that. And so now I see myself as a servant leader to lead the team and give them the tools that they need. And I say that the client should be at the center of every decision that we make. So I'm very passionate about what we do and believe in servant leadership and serving our community.
Thanks so much, Christina. It's great to hear kind of where you started was doing the work out in the field. And as you progressed, being able to bring that knowledge, that experience into everything that you do. Kelly, curious from you. Well, first, I'll let you introduce yourself and then share a little bit of your background. How did you get into this field?
Sure. I'm currently the executive director of Medi-Cal and CalAIM for CalOptima Health, which currently is the only Medi-Cal health plan we know here in Orange County. But I've only been here for about a year and a half, a little bit over a year and a half. Before that, I was the chief executive officer, CEO of a nonprofit in Los Angeles that works specifically with the unhoused population, primarily providing and creating recuperative care programs across Los Angeles County and Ventura County. I was there for 15 years, so that was a lot of my professional career. But educationally, I'm a social worker. I'm one of those purebred social workers, BSW, MSW, and I'm one semester away from completing my DSW at USC. So excited about that. The move to CalOptima Health was a lot of folks, I think, would look at it and say that, well, that's not social work. Why would you want to do that? And I think that it's a perfect example of social work because it's really trying to make an influence change at the system level. And with CalAIM, we really have been given that opportunity. We've been given an opportunity to make change at a higher system level. And CalOptima Health is incredibly dedicated to doing that, really in a space that includes design thinking and designing with our community at the center of that, similar to what Christina said. So I feel like I have never been a more powerful and influential social worker than I am with this position. It's been incredible, and it's just very exciting to see where Orange County is going.
Thank you, Kelly. For anybody who's watching today who doesn't know what CalAIM is, can you explain what it is and how is it changing the landscape? I know it's changing the landscape here, but I would love for everybody who's watching to have that understanding.
Sure. So the way I describe it most often is I say CalAIM is California's recognition that our ability to be healthy is determined 80% by things outside of the traditional healthcare system. So when we think about healthcare, we think about going to the doctor, going to the emergency room, going to the hospital, unfortunately. But we know that 80% of a person's ability to be healthy is not dictated by those traditional medical services. It has to do with whether somebody has a home, whether somebody has fresh fruit or fresh food and water available. They have green space with which to exercise, access to a job, transportation, education. We know that a person's ability to access these social determinants is really a bigger indicator of their ability to be healthy. And California is the first state that got that. And so in response to that, they have made services geared around those social determinants of health now available to its members. So now, for example, since we know that housing, since that's perfect what we're talking about today, is a social determinant of health, if an individual finds themselves unhoused, they can now get services to find that house, and that service provision is a benefit or a certain being funded by Medi-Cal through CalAIM. If they have a home but they're at risk of losing it, they could get tenancy services, and that will now be covered. So these are different benefits or services that weren't available before, but they are available now through CalAIM.
Perfect. Thank you so much for succinctly explaining that for us. I think that's really helpful as we dive into the conversation. And I will say that it has been just remarkable to see how this has been rolling out over the last couple of years. Tremendously good things coming out of CalOptima. And so a huge thank you to you for your leadership and bringing these new innovations to Orange County. So this is a conversation and a part of our series on mental health and homelessness. And so, Christina, I'm going to come to you first to help talk us through some terminology before we dive into this any further. So when it comes to mental health, what are some terms that we might hear when people are talking about mental health, and what do they mean?
Yeah, that's a really great question. So thanks for that. When we talk about mental health, I mean, it should be dovetails with, mental well-being, or like kind of simply how you're feeling today. But for some of our folks, they may have what we call an acuity level that is either mild, moderate, or more serious. And so for people that are experiencing mild to moderate impacts or symptoms from their mental health, they may be feeling some episodes of depression, or they may have had a traumatic event that occurred in their life that is impacting their well-being. And maybe they don't want to participate in something that usually brought them joy, or maybe they are feeling impairments or some difficulties with their relationships. And so this is what I think that a lot of us all go through on a regular basis, right? Of feeling depressed or anxious or adjusting to change. So for those kind of situations, we would consider that you're more on the mild. And then if it's maybe recurring, it's really impacting me more substantially, I might say I'm having moderate issues. Like maybe I had a recent trauma. Maybe I went through a big life change, like a financial change or a relationship change. I'm going through a divorce, or I have grief or loss, and it's really impacting me. I might consider that moderate. Then we have the more other end of the scale, which tend to be where county services reside, as far as that's where people think all of our services reside. And that would be for the more serious, seriously impacted. So we sometimes call this SMI, or serious mental illness. It's also sometimes called severe mental illness, because it is a category of kind of the severe diagnoses that have more severe, serious symptoms. And then sometimes we call it SPMI, which would be serious and persistent mental illness. So when people think about county services, they think about SPMI, or the serious persistent mental illnesses. And these are diagnoses and symptoms that are really consistent, that you may need support in order to recover from them, or you may need some type of level of mental health treatment. And that doesn't always mean medication, but some level of intervention. And then like I said, they're going to be ongoing. So it's not like, hey, this is a life event that is, that I think I just need some tools to help me recover. This is more serious, it's persistent, and it's impacting my ability to function daily. So these are the folks that are like, hey, I literally have not gotten out of bed for weeks. I don't feel like I want to do those activities of daily living that we call, like I don't feel like showering, doing anything that really involves self-care or engaging with others. That would be a good indication to me that my depression is pretty profound, and maybe I've had cycles of this throughout my lifetime. So that would give an indication of more serious mental illness. But I would be remiss to also not bring up, that we are really talking about behavioral health. And so for a lot of our folks, it's not just mental health, it's also how I may cope with my mental health that could then make me co-occurring, where I also have a substance use disorder or a substance use diagnosis. So maybe that's where I'm coping, or maybe that's like really how I've been living my life, of engaging in substances to deal with my traumas or to deal with my mental health, or just that's what I've become to rely on, and my substance use is becoming so profound that it's impairing my ability to function daily. And so when I think about some of my most memorable clients, I get it. When you're unhoused, that substance use might be your go-to mechanism to get through the survival of being out there and dealing with the repeated trauma and the hypervigilance, the anxiety of being unhoused and being in that survival mode. But also, I may have become to the point where the substances are now starting to control me, meaning that my goal and my focus every day has been, how do I get well by using that substance? How do I secure it? And what am I doing in my life decisions right now that are going to help support that substance use? So that would really give us an indication that, okay, your substance use is profound enough that it really requires some level of treatment or intervention in order to recover. That was a lot, huh?
So much information so succinctly into that response. So wow, there's a lot there. I want to come back to one thing you said at the beginning around SMI and the sort of shift that we're seeing away from the use of the word severe to the use of the word serious, because I think this is really important. One of the hopes from these conversations and dialogues is to really reduce the stigma around talking about mental health and acknowledging that every single person has mental health. Where we are on the kind of spectrum of wellness differs every day, depending on, as you said, circumstances that are happening in our life. But I think that's a really important moment. And so I want to come back to that and sort of underscore that. And from your vantage point, that shift to the use of the word serious, what do you think that means for us?
Yeah, I think that I agree that it really, for me, the reason why I choose to use serious versus severe is, it's client centered. So not only does it address stigma, but if I'm the client receiving that, severe might feel like something like, oh, I'm not going to recover from. And also that's something that that clinicians may tend to use, right? It's relevant to them when you're looking at diagnosis. And I'm not a clinician, so I guess I can say that that my belief is that it's relevant to them when it comes to diagnosing, documenting, really describing what this client is going through. But as far as me as a client, if I'm receiving that service, it's really less relevant. And so am I going to respond better to the term, okay, that's serious? It's almost like you're acknowledging and seeing me also by saying, yeah, you're going through something that's really serious, that may or may not feel like it's in your control. And I just think that I may respond better, or my client may respond better by let's talk about the seriousness of what you're going through versus really focusing on the symptomology and the diagnosis end and talking about the severity, right? Because that's really on the acuity scale, probably less relevant to my client who's actually experiencing it.
Thanks so much for digging in there. I appreciate that. Kelly, is there anything that you'd like to add into sort of the terminology or your thoughts on the terminology we use in this space?
I'm not even going to pretend that I can add to that. I think Christina did a phenomenal job of that. I've never heard serious versus severe, and I so appreciate that that shift and just the stigma, the consciousness of stigma in those decisions. I really appreciate what you said, Christina.
Thank you. So we are gonna, when we set this series up, we wanted to kind of follow the Venn diagram, because we have mental health, we have homelessness, and we know that these two things can exist without overlap, and then there is a place where they overlap. And so I want to dig into this, and we are going to just dive straight into the chicken or the egg situation. Do mental health issues cause homelessness? Or are they a result of homelessness? Or is it some kind of combination of everything above? And so I don't know who would like to jump into this one first. And so I will pick on one of you if somebody doesn't unmute. So Kelly, I'm coming to you. Get us started with this.
I'm happy to start that. So I think that is such a great question, and one that deserves to be discussed. Being unhoused or experiencing homelessness is traumatic within itself, and I think that's really important to acknowledge, and that the vast majority of folks, and that we're recognizing when we look at the study that was done by the University of California, San Francisco, are falling into homelessness for financial reasons, and that is why they're becoming unhoused. Now, you become unhoused, and like I just said, that is traumatic in and of itself. Living on the street, living rough, not having a place to go, having to figure out where you're going to eat, how you're going to be safe. If you're a woman, how you're not going to be attacked, take care of your children, God forbid. This is a traumatic experience, the results of which oftentimes trigger types of behavioral health issues. And so that then becomes a barrier to exiting homelessness. And I think that is really important to acknowledge, is that the causes of homelessness, of folks falling into homelessness versus why they cannot get themselves or be able to get themselves out of that situation, are far greater on that back end. So in your Venn diagram, And I'm not saying it's 100%. Of course, there are folks that have mental health issues that find themselves unhoused, but that is, I think, a small percentage. I think most of the time it goes the other way. The trauma associated with being unhoused is what causes those problems on the back end.
Thank you, Kelly. Christina, what would you like to add to this?
I think it's challenging in that I don't know that we have clear data, especially local data, that could tell us like, hey, this clearly came before and or after. So I think for me, and working in this space, I I'm not as concerned about when it happened or how, but more hearing the story of their journey, because you can look at, there's different beliefs on, if this was purely financial, if this was trauma that experienced, if it's your coping mechanism, is it just life circumstances happened, right? And then while you're out there, I would say that whether or not you had a severe or serious and persistent mental illness before you went out, or a substance use disorder, before you became unhoused, I think the fact is that everybody who's experiencing unsheltered homelessness or is unhoused, or quite honestly, housing insecure, right, is at some level experiencing traumas while they're out there. To Kelly's point, they're experiencing repeated traumas while they're out there. And the tools that they had for coping may not be available to them. The resources that they had that helped them through, hey, I was dealing with a challenging situation in the past, but now that tool isn't available to me, such as family or a partner or friends. And they might feel really isolated. So despite what happened that got you there, I would say that all of our clients, I would say at least have some type of level of impact to their mental health, as they should, because they, again, are going through that hypervigilance of survival, whether you're looking at Maslow's hierarchy of needs, or if you're looking at flight, fight, right? We just had this conversation yesterday. They added fawn or freeze. And so however you're coping with it, you're in that mode. And I think going through those repeated traumas, you might even pick up some new poor coping skills. I was going to say maladaptive behaviors, but or at-risk behaviors, but going back to that survival. And so that's why I'm such a proponent for recognizing housing first options out there, right? If we can give us some type of level of baseline, again, to Kelly's point of making like basic survival, not something that you're dealing with every day, and the trauma of being safe every day or getting food every day. If we can give some more stability and safety, reconnect folks to the community so they feel like they belong, then I feel like that's a great way to then to be like, okay, now that you don't have to worry about this basic need, let's talk about your mental health and your coping and your resilience and getting you back to being at hope.
Absolutely. And thank you so much for helping to make that connection between what is needed to become healthy in every aspect of life with the provision of housing. We started off with Kelly saying that has been the recognition, across the nation and here in the state of California, the recognition that there are so many things that go into help for a person. And that bridging that back to the housing first approach, which says, we're not going to be able to resolve anybody's homelessness until they are housed. And it's only when somebody is housed that now we can look at everything else that's going on with them and being able to bring them the services that they need to become healthy and to thrive again. And so I really appreciate you making that connection for us.
I think the point, I don't mean to cut you off, but you said I could, so I'm going to. I think the point of housing first, and there's a little bit of a bee in my bonnet when it comes to that, because it is absolutely, it's an evidence-based practice. Okay, it is not negotiable. It works. Evidence tells us that it works. Folks will say to me quite often, I look at your shirt, Vex, and they'll say, housing first doesn't work. We tried it, it doesn't work. And I always go back and say, if you tried it and it didn't work, it's because you implemented it incorrectly. I don't know what else to tell you. It is an evidence-based practice. It is fact. It has particular ratios. It has particular policies and practices. And if those are not followed, like anything, it's like saying, I made a cake and it doesn't work. So all cakes now don't work. Well, you probably forgot an egg, right? Or maybe you had the oven too hot. Or, I don't know, you use salt instead of sugar. But that doesn't mean now that all cakes can't be baked. You have to go back and look at your recipe and see if you missed something. And I just think that's really important, because sometimes folks think they've done housing first and it hasn't worked, and they want to paint the entire practice based on their experience. And I just want folks to hear that this is researched, like trauma-informed care. These are evidence-based practices that we know work. And if our attempt at doing them didn't, then we need to look at ourselves and say, did we implement this correctly?
Absolutely. And please interrupt me anytime either of you have a point that you want to make. I'm here to amplify your voices. So yes, more of that, and absolutely regarding housing first. Absolutely. Christina, you mentioned another part of what you were talking about was, when somebody is unhoused, what that does to somebody's mental health. So we've talked about, how there is this movement across the country and in the state to recognize the value of housing and what housing does to help improve somebody's mental health. So the flip side of that, when somebody is unhoused and they don't have a home, what does that do? How does that impact somebody's mental well-being?
Yeah, great question. I think a few things come to mind. One is I'm really trying to dive deeper into the sense of belonging. The fact is, when you feel like you don't belong in a community, you don't have those kind of supports. Actually, studies have shown that you're at greater risk, right, for mental health issues, physical health issues, and a less sense of well-being. So one of the things that I know that our team says a lot is, in doing street level outreach work, is that our clients just want to be seen. They want to be heard. And so I always say, sit in the dirt, pet their dog, have a conversation, hear their story, make sure that they know that they are being heard. So going back to your shirt, I agree. Ask me about homelessness. Let's have a dialogue. Let's take off, dust off the stigma or any associations that we have on that, and recognize that these folks are part of our community. How do we connect them back to the community and give them that sense of belonging? The other thing that I feel like our team, or the lens that I like to offer when providing services, is really looking at SAMHSA's, which is a substance abuse mental health association. See now, the letters, and they're federal, giving us kind of guidance on interventions for folks that have mental health or substance use disorders, and they were really supportive of the recovery model. And with that, at the center of it is the idea of instilling hope. So for our folks that are out there unhoused, if I felt like, hey, I'm distrusting of the system because I feel let down or betrayed by you before, if I feel like I'm not connected and I don't have any other supports, and then you as a service provider come out and you're telling me about this, and I'm like, I've tried that before, and maybe to Kelly's point, I tried a program and they forgot the eggs and the sugar, I'm not going back to that, right? And so I keep experiencing new traumas to survive. I'm also maybe not feeling connected to the community. I'm unseen. And then I also don't have those supports, and I don't trust the system. So I feel like it's on us as providers to work harder than the client every day, go out there where the client is at, make sure that they're seen, and then help build and support their resilience, and offer them a whole host of different options until we can find the right option that is appropriate for them. I feel like that's our job, is bring out the whole cafeteria plan, right? And be with them on that journey. As the team always says, like, hey, I'm going to be there until they're ready for change. So we also believe in the harm reduction model. A client may not be ready until they're at that stage of change, that they're ready for action. So while they're thinking about it, or pre-contemplative, or trying it out a bit, testing the water, I feel like it's our job as providers to help them build the resilience, the coping skills, give them the support, and just be there as that trusting person until they're ready for action. And then we need to have a ton of tools in our tool belt to be able to offer them and say, hey, does this one fit? And they're like, no, all right, what about this one? Or what about this one just for tonight? Just for a week. Could you try this for a week? That's really what the harm reduction model is about. But like I said, I also believe in the recovery model, which is about fostering resilience, client-led, fostering hope, and that connectedness.
Christina. Kelly, what would you like to add into this?
I love what Christina said about that these are our neighbors, and I wanted to just to highlight that a little bit. Or these are our community members. It's not just, we know that, we say that not just because we feel, like good people, like, oh, these are our neighbors. They quite literally are our neighbors. I mean, that's what the research tells us. I mean, the University of San Francisco study said that, upwards of 90% of folks that are experiencing being unhoused in California come from California, right? And we know that the survey that we just did recently here in Orange County mirrors that, if not even higher, to say even more than 90% of folks that are experiencing being unhoused here in Orange County are from Orange County. So they are quite literally our neighbors. And I think that is a really good point to make, because, as the social norm, which is the unfortunate social norm of saying those folks have made a decision in their life that somehow I have avoided making, and therefore I am not experiencing what they are experiencing, and therefore I can somehow justify that they are not worthy of that assistance because they have made the wrong decision. I think over and over again, and these forums are so important to be able to say that is just not true. It is not true. They've had unfortunately could not afford rent because housing is just too expensive. Some sort of event, they've lost a spouse. Something has happened that has created a financial world with which they could not survive. And they were here in Orange County, our neighbor, when that occurrence transpired. I just think these are facts. These are things we need to realize, and that it is our obligation. These are our neighbors, quite literally our neighbors. So what are we going to do to help? It's not a choice. It's not something that somebody's made the wrong choice in their lives. It is unfortunate circumstances, and we have an obligation, I believe, to help, but literally our neighbors.
Thank you, Kelly. As you were talking, I was reminded about the information from a poll that UCI did earlier this year. They reached out to residents in Orange County to find out what are the things that people are most worried about and concerned about here in our community. And the top two were homelessness and housing affordability. And what really stood out to me from that data set was that 55% of people either knew somebody who was currently homeless or somebody who was homeless in the past. So 55% of people in Orange County, homelessness has become much closer than I think it has been in the past. And I'm hoping that that's going to do something to break down this stigma, these thoughts that we often see around why people fall into homelessness. Because it's, so many of us are at risk. So many of us are one missed paycheck away, one illness away from falling into that cycle, where we don't have enough money to pay our rent, and then the knock-on effect of that. And, it is a very difficult thing to climb out of. And one thing I wanted to just kind of add in around the causes conversation was we have a lived experience advisory committee for our continuum of care here in Orange County, and we asked them to film a video for us that we've used at some of the in-person events we've had this week. And they were talking about causes of homelessness and the impact of homelessness, and they very clearly articulated that the impacts and the challenges of being homeless lead to those mental health struggles, the anxiety, and can lead to some of the coping mechanisms that you were talking about, Christina. And so that was just really powerful to hear it directly from people who experienced homelessness here. And one of the other things we asked them about was navigating resources, and what that's like to engage with the system and some of the challenges that there are around that. And so I want to kind of move us to that in our conversation. What is it like? What do you know about for somebody who is unhoused and who is struggling with mental health? What's it like for them to navigate through the systems to access help? And Christina, I'll start with you.
Well, interesting you asked that, only because just yesterday, one of my outreach supervisors said, she said, I flat out tell clients that, yes, the system is complex. That's the whole reason why I have a job is to help you navigate the system, because finding the unique service that is available to them that also kind of fits what our matches, aligns with their values, aligns with their experience, is challenging. It's one I think we need to go through the journey to find out what their traumas are, to find out what might be appropriate. And again, it needs to be client-led and it needs to be voluntary. So although there may be, I mentioned that cafeteria, I always thought of myself as like having like a tool belt or a bag with different tools in my backpack that I'm going to take out. I may not have the right one yet. And so part of my job then is to find that program or that tool. And each has its own criteria, funding source, access point. And so I don't think that it's fair to say that this person who's dealing with where am I going to sleep tonight? How can I be safe? And what am I going to eat? Who's going to watch my stuff while I go to this appointment? Like just so many things, that hypervigilance that they have to deal with to also figure out how are you going to navigate these different systems that may be, unless you're in the system, you may not even know how they're connected or where they're to start. We learned that having no wrong door as a mental health system, we learned that it actually was more confusing to clients because they're like, no, now I found that I have multiple wrong doors because everyone that I call, like, oh, that you need to be this in order to qualify for that service. So having someone to help navigate you through that process, be your partner. And then I also want to throw out there about trauma-informed care. So we already talked about people who are experiencing unsheltered homelessness are experiencing being unhoused, that they're experiencing trauma that got them there, multiple traumas while they're still experiencing it. So really all of our services, resources need to have a trauma-informed lens so that we don't re-traumatize the client. So as I'm accessing these different resources, and maybe I am just a rock star at navigating it on my own, I might have to tell my story over and over again. And as a system, we need to be hyper vigilant and work diligently to not re-traumatize the client while they're trying to access those different services. So again, that's how one person to help you through that journey. And for most of our clients, they don't have the friends or the family to help support them through that. So finding a service provider, that's either going to be your case manager, your outreach worker, your whoever that touch point, your navigator, whoever that touch point is going to be that you can trust, that has heard your story and can help you navigate the system, I think is really key to getting them there. And then I also wanted to throw out that just because we get somebody housed doesn't mean that all that goes away, right? Like suddenly yay, I'm all good. But helping them, supporting them work through what's going to help them stay housed, because so many of the times we see that our clients are still on their recovery journey, right? And maybe they're still engaging in substances. They're still challenged with their mental health. It's not like suddenly everything is better, but it just gives us that time, that space to help them address those concerns. But we need to do everything we can to wrap services around that client and help them build those life skills so that they don't end up back being unhoused or unsheltered.
One of the things I know we talked about when we were preparing for this conversation was being able to have, as you were kind of saying, Christina, like the cafeteria. So having access to or having a lot of different resources for somebody. And so I know that both of you are at different agencies. Both of your agencies have got different resources and services. And the way that I sort of see it, it's this beautiful sort of layering. And I don't see this as competition, but I'd love to hear from either of you who wants to kind of jump in here. Talk a little bit more about that, having this menu and this sort of diverse approaches to offering resources.
I can start that because Christina and their services, the county services, clearly have a huge impact on the county and have been here for a long time. And then here comes CalAIM, right? It's like here comes the new kid on the block kind of thing. And health plans really have the discretion and the ability to implement CalAIM in a lot of different ways. Most, I would argue, health plans have been a little bit more tentative in how they've rolled those services out. And they've done a little bit at a time, not all of the services, maybe just putting a toe in the water. CalOptima Health has like dove into the pool, right? I mean, hand on nose all the way in. And one of the reasons that we've been able to do that is because of our great partnership with the county and our ability to do what you just said, Bex, is to be able to layer services. I say all the time that homelessness is a complex issue. It requires a complex solution, and it's unrealistic to think that one entity or one agency can magically have all the answers to everything or the funding, quite honestly. So our ability to layer those services, I think is imperative. One great example I will use is our street medicine program. So, we were required by Department of Healthcare Services to implement a street medicine program. But O&E already exists in this county. They do exceptional work. They're all over the county, but they cannot be the medical provider, a detailed medical provider for every single individual. Or can they be their enhanced care manager and their housing navigator? And not everybody is ready for that. And so the ability to be able to say, here is, kind of almost like a boutique kind of program that's more specific and drills more down, that can layer on top of another program. The way I like to say, it's like O&E is like large and it can only go so deep, where street medicine is very, very narrow, but can go deeper. So they layer on top of each other quite nicely. So I think that's one example of how that works. And the county would be in a far worse position if either of those programs didn't exist. And it would also be in a far worse position if we saw ourselves as what you just said, competitors, because we're not. We're layering on top of each other. It has been a pleasure to watch that grow. And I would be lying if I said it was absolutely perfect from the beginning, because relationships are not like that. Relationships build, and they have to have trust. And then on top of trust comes healthy conflict and resolution. And then all of a sudden you start having success. And I think we're really starting to see that, because the trust had to be developed. And then we're building on top of that. It's actually really exciting to watch.
I'd like to add to that too. I absolutely agree. We always say that it takes a village. I also say that I don't think that any client is resistant to services. I think we need to find the right service for that client, and that's on us. And that's on building that relationship. But I also often think of Margaret Mead's quote of, that never doubt that a thoughtful group of concerned citizens can basically make the change. I'm butchering it, but indeed, it's the only thing that ever has. So by us coming together, I think that people who work in this space are servant leaders. They are completely dedicated to the clients. I think it's great to have stakeholder input, people with lived expertise, also providing our services, and being culturally diverse. I always say that, vets speak vet. You need a veteran to connect with vets. Peers speak peers. Really seeing folks who have had a mental health issue and now they're in recovery, and knowing that that's a journey, and how can I support you on this journey? So having like what Kelly was saying, having it being approached by different disciplines that's really going to resonate with that client, I think is the most respectful way that we can connect with them, and also giving them the control. It is client led. So let's let you know what's available and then help you get there.
Absolutely. Thank you to both of you for your really insightful and honest responses to that question. I want to, people have tuned in today because they are curious about this overlap between mental health and homelessness. And I want to make sure that I ask you this question. How can the people that are watching be a part of changing the conversation when it comes to mental health and homelessness? Christina, I'll come to you first for this one.
I'm gonna say again, I think one easy way that you can do it just today is recognizing those folks in the community. So that concept of belonging, inclusion, and hearing their journey, hearing their story, and just acknowledging that they are our neighbors, as Kelly said. I think that's one way that we can do it. The other is to dig in, as you keep saying, like, let's dig into this space and not be so fearful of it. The more that we create distance and say, hey, that couldn't happen to me, or and don't acknowledge, right, the landscape that is out there, that is our county, that is our community, the more that we're in that space and kind of not acknowledging it, I think it is a disservice. So leaning into that space and not being fearful of people who are unsheltered or unhoused. And if you are uncomfortable with that, then help support your professionals and your providers that are ridiculously passionate about it and are comfortable in that space. How can you support those who are doing the work if you feel uncomfortable making that connection on your own?
And I'll just add the layer on top of that, which is vote. Vote for the right things, vote for the things that will increase services, vote for the things that will bring permanent supportive housing into your communities, vote for the policies and practices that we need in order to be able to advance the services that are so desperately needed. We have the ability to make it happen.
Absolutely. And not just that, share this video, share part one on this today's session will go up onto the United and Homelessness YouTube channel. And so if you want to share this conversation with any friends or neighbors or post it on your social media, it should be up there in 24 to 48 hours. We'll email everybody who signed up, letting them know that it's gone live. But we really do want to be able to make resources available to encourage dialogue. And I truly believe in the power of conversation and just being able to be open and honest and talking about things that once had some stigma attached to them. I really believe that the more that we converse and dialogue, the more we're going to just reduce those stigmas. So I want to say thank you to both of you. I asked this question to the people in part one, and I'm going to ask it to both of you as well. Is there any kind of resource that you would like to recommend to people if they are interested in digging in? Is there a book, a podcast, an article, anything that you're like, you know what, this has been really helpful on my journey? And what would that be?
Well, I'll tell you, this is not necessarily about the unhoused in specific, but one of the best books I've ever read, and one that really, I would say, changed me as a professional is Kendi's book, How to Be an Anti-Racist. I've read it now 3 times and I've listened to it. And every time I do, I learn something new just about the policies and practices, what exists and how policy is necessary to make systemic change. So it's a very impactful book.
Thank you, Kelly, for that one. Christina, how about you?
I think if you want to learn more just about mental health and substance use disorders, and I mentioned SAMHSA earlier, the National Institutes of Health have a lot of great resources. Also for outreach workers, there's some great tools on there with SAMHSA. NAMI Orange County is really great because it can teach you about, like, if you have a family member and how do you be an advocate. I was like, there are a lot of different resources out there. I guess I am trying to learn more about, like I said, that sense of belonging, and just received a book called Intra-Connected, and that's next on my read list. So I haven't read it yet, but heard wonderful things about it. But I really like this idea of recognizing that we're a community, and how do we work together and lift each other up.
Absolutely, my community has been such an instrumental part of my life, and the times where I have struggled, the times where I've had traumatic things happen that have really impacted my ability to function, it has been my community that has rallied around me and provided that place of hope. And so I absolutely hear what you're saying, Christina, around the power of people believing in you, being a listening ear, cheering you on, just creating space for you to be sad or whatever it is that you're feeling in response to something awful that's happened in your life. We can't put a price tag or a value on that just sense of being able to support each other and recognize each other's humanity. So thank you for providing those resources, both of you. Those sound great. I've got 2 more books to add to my reading list after this, so thank you. And as I wrap up today's conversation, I just want to say we've got a couple of minutes left. Is there anything that you didn't get to say earlier that you want to say?
Just for me, just thank you for this opportunity. I think this is just so important. I just always applaud the work that you all do there and making these conversations happen. So thanks a lot, Beth.
Agreed. Thank you to Beck and to United Way that you're making this a priority, that you're shedding some light on it, not backing away from it, and really engaging thoughtful discussion and engagement about it. So thank you.
Thank you to both of you for joining us today. And thank you to everybody who signed up, who sent in questions to help shape today's conversation. We will be having part 3 coming up, and I'm sure a link popped into the chat box where you can sign up for part 3. And on the screen is going to come up some local resources for addressing mental health crises. So those should be popping up on a PowerPoint slide any moment. I want to say thank you again to Kelly and Christina for joining me for today's conversation. I so appreciated your insights. We look forward to seeing everybody again in 2 weeks for part 3 of this series. A poll has popped up. If you have a chance to quickly respond to it, it's just a couple of questions. It always helps us to shape these conversations on our community chats as we move forward. So I want to say thank you to everybody, and I want to wish you a wonderful rest of your day.